Hello, everybody. Thanks for joining us for our official launch of the Black Lives Living Well learning series. My name is Dr. Lisa Dennis, and I'm your host for tonight. Um, we have people joining us from Nova Scotia as well as Quebec. And I just want to let you know a little bit about HAWC. It's the Health Association of African Canadians. It's an organization that's been around for 25 years, since 2000. I'm the co-president-elect here in Nova Scotia. And I'm originally from Montreal. And we pretty much fight for health policy change for Black people in the system. So we do a lot of learning series, educating of our members, Black members. We meet with people within the province, within the healthcare system, within the government, to find ways to change healthcare policies so that it better meets the needs of Black people. And we have we're involved in research. We support different people's research if it's for Black health. So we're involved in a lot of things. I'll talk a bit more about HAWC a little while after the presentation. But I wanted to welcome you and welcome Lisa Smith. She is going to be facilitating the conversation tonight on breast health. And if you have any questions, please feel free to put in the chat. We'll probably wait for the end to be able to answer your questions. But you'll notice that on Lisa's slides there's the little there's numbers on each slide. So if you want to record the number of the slide and put your question next to it, and then just submit that, I'll take a look at that, and then we'll ask questions later on. We've been through this presentation already, and there's lots of information here. And so I think you'll enjoy tonight's presentation. So I'll tell you a little bit about Lisa. Another Lisa Smith has been a medical imaging technologist since 2005, with a specialization in digital mammography since 2007, and as an autonomous breast ultrasound technologist since 2018. She presently works at the Anna La Berge Hospital in Châteauguay, Quebec. She's an advocate for breast health and has been delivering presentations since 2015, and most recently has focused on breast cancer awareness and started a breast wellness group with a mission to support and connect and facilitate discussions on this important topic. So the goal for Black Lives Living Well learning series is really to teach you the hows of how to live a good life, and not just making it too academic. So I hope that you'll enjoy tonight's presentation, and I'm just gonna get Lisa on the screen so you can actually see her. Okay, Lisa, you can feel free to start whenever you're ready.
Okay, thank you, Dr. Lisa. Thank you for everyone that joined us. As Dr. Lisa said, I've been in the medical imaging for 20 years. And my story is I started advocating and going out to our Black community about 7, 8 years ago. A young woman came in through the emergency with very acute breast symptoms, and she's a classmate of my sister. And 3 weeks later, she passed away. And that was very painful because same age as my sister, early 40s. And why are so many Black women dying from breast cancer when we have so many tools, so many different support systems, so many different modalities for screening? So I just like to advocate, and I'm going to be talking about our breasts, the breast types, with mammogram and ultrasound to illustrate that. We're going to talk about the male breast cancer, the protocols for breast screening, and then we'll do a short self-examination. Okay, so this is a female anatomy. The evolution of female breasts is all related to hormones, whether it's natural or artificial hormones. The breast is a gland. It's made up of fibrous breast tissue, glandular breast tissue, and fatty breast tissue. You have the ducts that dilate during pregnancy, breastfeeding, and it also atrophy or closes after menopause. You can see the lymphatic
Lisa, I'm just
system.
going to interrupt you for a second, Lisa. We can't see you on screen, so we'd love to see you on your phone, Lisa.
Are you
at your
seeing me
camera.
now?
No,
Can you?
no,
Yeah?
we can't. No, we can't. Still can't see you.
Okay.
We saw
Is
you a
it
second
off?
ago, but I don't know where you went.
Okay. Oh, my video is off.
Your video, yeah,
Sorry.
video on on your phone. Thank you.
Okay, there. Okay.
Not yet. We'll just give it a second to. Okay, we see you now. I'm gonna put a pin
Okay.
there. Okay, thank you.
Okay, very good. Okay, so like I'm saying, this is the female breast. It's a gland. It's made up of glandular, fibrous, and fatty breast tissue. We have the ducts that dilate during pregnancy, breastfeeding, and it's atrophy after menopause, meaning it closes up. Here you can see the lymph node. It extends to the chest wall, the outer side of the breast, and towards the lymph node. The tail of the breast extends towards the armpit, and the tail of the breast, this area, 55% of malignancy or cancer is found in that area. The breast is also related to the groins. The milk duct from the armpit extends towards the groin area. Now, let's talk about the physiological aspect of the breast. During pregnancy, breastfeeding, the area around the nipple becomes dark. This pimple, it becomes bigger, or it's a gland, it's like a sweat gland. Also, let's continue. We have what we call atopic breast tissue or accessory breast tissue under the armpit. And this is an abnormality from birth. So it's normal sometimes with these type of abnormality to have accessory breast tissue in the groin, but more common in the armpit area. This is an image of a mother breastfeeding 3 months. There is a lump under the armpit. This is breast tissue actually, and it's an engorgement, just like it engorged in the breast. The ducts is blocked, so she will need to compress and massage with either warm or hot. Okay. This is showing the parameters of the breast. So those of you who have mammograms, you complain that it's very painful. I always say it pains to be beautiful. So 5 minutes of pain for your health is okay. So sometimes we compress and we need to get the chest wall. And some people complain, you're on my collarbone or my clavicle. Well, we need to be at least 1 inch inferior to the clavicle, the collarbone, 1 inch to the shoulder, the shoulder. We need to get the chest wall to get the pectoral muscle. We need to get the outer border of the breast, and we need to get the junction where the breast and the abdominal wall touches. Here is another image. So this is showing you an angle. Very important to have this angle open when we position in. This is the junction of the breast and the abdominal wall. It's called the inframammary fold. Sometimes when we're trying to open that angle, people are self-conscious and they say, oh, my stomach is big. We don't notice your stomach. We're just paying attention to have that angle open. Okay. Here is an illustration of the breast imaging. So we do routine mammogram. We do 4 images, 2 for each breast. This image is a flat image. It's for the upper and lower part of the breast. This curve here is your pectoral muscle. Very important why we need to go towards the chest wall. In this flat view, there's a 30% chance we get the pectoral muscle. And this view is the side view to get the chest wall and the outer aspect of the breast and to have that angle open at the junction of the breast and the abdominal wall. This is the pectoral muscle. It's kind of curved, so it's very important that you are relaxed when we position in so that we have such a curved pectoral muscle. This line is indicating the distance from the pectoral muscle to the nipple. So if we have a difference of 1 centimeter between the flat view and the side view, we know we have an ideal mammogram for optimal diagnostic. Here is a picture of the breast, a mammogram. So this is the correct positioning of the breast. Like I showed you, it's the flat view where you get the pectoral muscle 30% of the time. This is the fat glands, and this is the fibrous gland. Here is the pectoral muscle. These little circular area is the lymph node. Hence, very important. We need to go very far back or posterior to get the pectoral muscle, and you can see the angle. So this is a mammogram. This is one of the tools used for screening mammogram with low dose radiation. We use 28 kVp. People are concerned they don't want to do mammogram because the dose is high, radiation will cause cancer. But just for your information, taking a flight, you get more dose, radiation dose than doing your yearly screening mammogram. Okay. This is an image showing a patient that had previous cancer. This area shows the scarring in the breast. The nipple is inward because of the scar. And this second image shows calcification. We all have calcification in our body, but the calcification in the breast, some of them could be cancerous. We need to do extra views, a biopsy to confirm if it's a cancer. So with the correct positioning, we went very further back, posterior. We were able to locate calcification. We did a biopsy. It was a cancer, so she had a recurrence cancer in the breast. Here's another image showing you correct positioning. This little area here, we're wondering, is it a real lesion or is it just a glandular breast tissue? With the second imaging, we went further back and it showed that it is actually a mass. Okay. Now we're going to talk as women, we have 3 types of breast tissue. We have what we call the fibrous breast tissue. The second type is the fibroglandular breast tissue. The third type is the adipose fatty breast tissue. It's very important that we know what type of breast tissue we have. Usually it's on our report. So I hope with me explaining to you what it is, when you read your report, you will be familiar with what type of breast tissue you have. So here is a mammogram that's showing the density of the breast. Density is the difference between the fat and the fibrous gland. So this is a dense breast, the first type I spoke to you about, fibrous breast tissue. It's common in young girls and women before menopause. This image is a mammogram of a flat view. You can see the pectoral muscles here. You can see the extent to the armpit. Remember, I told you the tail of the breast, if you can see, it's extending towards the armpit, and 55% of breast cancer are found here. This is the nipple and a nipple marker. We always need to see the nipple in profile because this is the most area where we miss cancer. And at this area, the angle, it's the inferior part, the junction of the abdominal wall and the breast. So if we look at the fat area and the fibroglandular breast tissue, we will say this type of breast is an extremely dense breast because it's more than 75% fibroglandular breast tissue. That's the extremely dense breast. The dense breast, the fibroglandular breast tissue will be between 50 and 75%. So on this image, it's like cloudy skies. It's hard to see any masses. So people with dense breasts, extremely dense breasts, should complete their exam with an ultrasound. Now I'm going to show you the ultrasound of a dense breast. The anatomy ultrasound is actually a tool used like a wave sounds that gives an internal structure that transmit into a screen. We use a transducer, we use gel to scan so that we can get an image which is projected on the screen. So this is the surface of the breast. This is the fibroglandular breast tissue. This is the pectoral muscle. This is the lungs. We're only concerned about the area above the pectoral muscle. So with dense breasts, you see it's very, very hard to see on ultrasound, but with scanning, it can spread out the breast tissue. Okay, this is the second type of breast tissue, and this is common in women 30 to 50 years old, childbearing age. It's 25 to 50% glandular breast tissue. So this is the side view again. This is the pectoral muscle. This is extending to the armpit. This is the tail of the breast. This is the fibroglandular breast tissue. So this is between 25 to 50% fibroglandular. This is the fat. Again, the nipple in profile with the nipple marker. This here is what a marker that patient had a biopsy. And this is what a marker looks like a surgical clip when you do a biopsy. 90% of the time we do a biopsy, we put a marker in the area. The marker is a guide. For example, if the patient is on chemo or so and the mass shrinks, the marker will give you the guide for the surgeons to take out the area. Also, if it's a non-cancer, the marker stays in your breast for life. When you do your imaging, we see it. At the airport, you don't need to declare because it's like a surgical clip. It's made of titanium, it's 4 millimeter, and it has no magnetic interference. So second type of breast tissue, fibroglandular, common in women 35 to 50. This is the ultrasound. Here is the surface of the breast. Here is the gland. You see it's very nodular, this type of breast tissue. Here is the pectoral muscle and the lungs. Now, the third type of breast tissue, it's the fatty breast tissue. It's common in women after menopause. This is less than 75% fibroglandular breast tissue. With the fatty breast tissue, it's like clear skies. You really do not need to be screening with ultrasound to complete your exam unless there are changes on the mammogram or there's a clinical indication. And actually, the type of breast tissue has no interference with the sizes of the breasts. Here is the ultrasound of a fatty breast, women after menopause, 60 and older. This is the surface of the breast. This is the gland, this is the pectoral muscle. So you see this fatty breast, it's like smooth contours, the contrast. And something else I had to say. Oh yeah. So we said women after 60 should have fatty breasts, but some women after 60, after menopause, still have dense breasts, and that all has to do with hereditary. So implants. There are two ways implants are placed, either in front of the this is the pectoral muscle, or behind. In this image, the implant is behind the pectoral muscles. A routine mammogram exam or 4 exam, and people with implant, we do 4 exam with the implant where we do not compress, and we do another 4 exam where we displace the implant or we push it away. So in total for images for women with implants, 4 exams, okay? So this is the one where we include the implant with no compression. And the second one is where we displace the implant, so if there are hidden masses or so. And again, there's the pectoral muscle. The implant is behind, okay? And this is the side view on mammogram, for the medial to the outer aspect. Now, this is the flat view, and this is the implant behind the pectoral muscle. This image is without compression and the implant in place. The second view is with compression and we displace the implant. Here's the ultrasound showing the implant. This is the skin surface. This is the gland. This is the pectoral muscle, and this is the implant. This dark area, this circle is a cyst. A cyst on ultrasound, because it's a liquid, it's dark. We don't worry about cysts. We don't follow up cysts. Cysts comes and goes. Some of them you can feel them, some you can't. Again, it's all related to hormones. After menopause or without any hormones, you should not have cysts, or you should have not too many, or they should be smaller. Okay, here's another ultrasound showing a benign mass. It's a fibroadenoma. Here is the breast tissue, the surface. Here is the gland, the muscle, the pectoral, and the implant. Now, this image will show implant that's placed in front of the pectoral muscle. This is the pectoral muscle. This implant, as you can see, there's a rupture. It's an old implant. It's 40 years old. These view are with the implant, no compression. The ones here are where we displace the implant and we compress. This patient, because of the rupture and because it was 40 years old, I'm not sure, depends on the type of implant. You should change your implant at least every 20 years, and this is over 40. So because of the rupture, the patient had the implant removed. So this is the side view, and this shows the residual implant that leaked. This is the flat view, again, residual implant that leak. This is the ultrasound, and this sac is the leak implant. They cannot take it out. It has to stay there. So this is the surface. This is the glandular breast tissue. And this is the sac of residual implant. And it's in front of the pectoral muscle, so you cannot see the pectoral muscle here. Okay, we're gonna talk about mammogram, tomosynthesis. So I'm sure everyone heard about tomosynthesis, the 3D. This is an application that's added to the routine mammogram to help to section out overlapping breast tissue. The dose when we do a 3D, it's not higher. It's just a difference of with the regular 2D, we have 1.4. With the 3D combined, 2.65. And the FDA, the average should be less than 3 milligray. So it's under the dose level. So it's okay to do 3D. Now, this is a mammogram. This is the flat view for the upper and lower part of the breast. And this is a routine mammogram. As you can see, this is a dense breast. It's more than 50 to 75% fibroglandular breast tissue. This is the fat. This is the nipple in profile, and this is the marker. So on this breast, like we could use our analogy, it's like cloudy skies. We do not see any mass in this breast. And with the 3D, we can see a slight distortion. Distortion is like fiber webs or so. It's really distorted. So 3D, that section out the breast, it's good for picking up masses. It's good for picking up distortion in dense breasts. Okay. So in the end, this was worrisome. It was biopsy. It was a cancer. Now we're going to talk about ultrasound. I mentioned it before. It's sound wave which verify the internal structure of the breast. A transducer is used where the wave is reflected onto a screen. We use different types of transducers depending on the breast type or depending on how deep we want to look within the breast or the lesion is in the breast. On ultrasound, we characterize lesion or masses found on ultrasound. So we look at the shape. Is it round? Is it oval? Is it irregular? We look at the margin. Is it well circumscribed? Is it indistinct, speculated? We look at the orientation. Is it wide or is it tall? And we have patterns that we use to characterize lesions. So when it's dark gray, or is it bright gray, or as I showed you before, the cyst, is it dark, etc. I'll give you an illustration of how malignant and benign masses are characterized. So the margin, well circumscribed or obscured, we are not worried about lesion that has this margin. We will go to routine follow-up. Something that's microlobulated or curvy like this, it's a possibility that it could be non-cancerous or it could be cancerous. So we do a 6-month follow-up for lesions like that. With ill-defined speculation, for sure it's worrisome, we do a biopsy. Here is the shape, round, oval, routine follow-up. Lobulated, again, kind of like wave, like a cloud-like shape. We follow up 6 months, and anything irregular speculated, we do a biopsy. Here is an ultrasound to illustrate some of these lesions. So anything that's dark, it has liquid in it, and this white area, it's a cyst. This is irregular shape, and it's dark gray. For sure, it's something worrisome. We'll do a biopsy. This area, it's like obscured, like you have a well-defined border here. It's well-defined margin, but just the shape. This dark area is a cyst, and this area, I mean, it's a liquid, sorry, and this area is liquid too, but it's thick. So whenever we have thick liquid, it looks grayish. And when we have the classic clear liquid, it's dark. So we're not worried about this. And here's another one for sure. The shape, the margin, we're worried about it. We'll do a biopsy. Now, we'll talk about non-cancerous or benign masses that are found in ultrasound. Some of them you can feel them, or some of them just by doing a mammogram or screening, you see them. So the first one we'll talk about, and they all have the same characteristic, is PASH. It's just an acronym for a non-cancerous lesion found, and it's common in women of childbearing age. They can feel it sometimes. Here's the mammogram. So this is the flat view that shows the upper and lower part of the breast. This is the side view that shows the middle and the outer part. And this is the palpable mass that's seen. On the mammogram, we're not sure if this mass has liquid in it or if it's a solid lesion. So with the ultrasound, this is the ultrasound. So this is the surface of the breast, and this is the mass. It's oval shape. So for sure, the patient can feel it. And inside of the mass, there's glandular breast tissue and liquid. So this is a patch. It's something that's not worrisome. We usually follow it up for a 6 months period, for a 2-year period. If there are no changes, you go back to your routine. Now, fibroadenomas, very common in young girls, women before menopause. Some of them you can feel them, some of them you cannot feel it unless you do imaging. And here's the mammogram. So as I mentioned, this is a dense breast. So this is the fat, this is the side view, this is the pectoral muscle. This is the fibroglandular breast tissue. So again, on the regular mammo, the 2D, it's like cloudy sky. It's hard to see if there's any mass. Now with the 3D, when we section it out, here you can see a mass. Now that's the side view. This is the flat view. And here we see the mass as well under the 3D. So it's always convincing when we see the masses on both view, we're concerned that it's real. If it's on one view, we're not sure if it's real. Here's the ultrasound. This is the surface, and this is the mass, this is the pectoral. So it's a fibroadenomas. Again, a lesion like this, we follow for 6 months period for 2 years. If there are no changes within the 6-month period, you go back to routine after 2 years. If there are changes, a biopsy is usually done. Here is a different type of fibroadenoma. It's called like juvenile fibroadenomas. This type of fibroadenoma, it grows very quickly and you can feel it. So this is the surface and you can see it's right under the surface. And because it grows very quickly, you have to take it out. Okay, hematoma. This is just fatty, fibrous, glandular breast tissue that all comes together and you can feel a nodule. Uh, this is the mammogram. This is the mass here, and you can see the texture of the mass is same as the fibroglandular breast tissue because it's just glandular and fatty breast tissue that forms a nodule. Here is the ultrasound, the oval shape. This is the mass, but the texture of the mass and the glandular breast tissue is the same. Okay, gynecomastia. Gynecomastia is something common in males. At birth, infant can have gynecomastia. It's a swelling around the nipple, increased gland around the nipple, and it's usually an imbalance with the estrogen and testosterone. They have tenderness around the nipple area. You have the infant, you have the teenager, and some male are influenced by medication that they take, antidepressant, prostate medication. Young teenagers that smoke weed can have gynecomastia, increased gland in the breast area, and even when you take steroids. So here is a mammogram. So this is the side view, and this is a male. You can tell because you see how much pectoral muscle is here. So this is a male that has gynecomastia. This is the increased glandular tissue around the nipple. This nipple marker indicates the nipple. And this patient has gynecomastia as well as he's a BRCA carrier, one of the genes mutation for breast. This is the ultrasound, and this is the gland around the nipple area. So you see there's an increase of the gland. This is the breast tissue. This is the pectoral muscle, and this is the lound. And here's a physical image of a teenage gynecomastia, swelling around the nipple, tenderness. And here is an ultrasound image, and this is actually a mammo of a male. So this is a male that had prostate cancer. He's taken medication for prostate. He felt a lump in the breast. The ultrasound indicates a cyst when it's dark. A biopsy was done. You can see this is the clip. Like I said, 90%, 95% of the time, we leave a clip in the breast. And it's a cyst, it's something non-cancerous. We don't need to bother with it. Here is a mammogram, the side view of a male that has breast cancer. This male is in his 50s. His mother had breast cancer. This is the mass. He could have feel the mass. There's some calcification here, but you may not be able to see clearly. This is the ultrasound of the mass. A biopsy was done. It's a cancer. This is another mammogram, the flat view and the side view of a male that had or male breast cancer. And this is the mass. The patient was able to feel that mass. This is the ultrasound showing the mass, and a biopsy was done, and it indicates that it was a cancer. Okay, where am I? Yeah. This. Okay, and this is a male. Like I'm going to mention in the protocol for screening, people with certain mutations has a high risk of breast cancer. So in this male, he has the Coden's disease. The Coden disease is like fatty lumps all over the body and the breast. And people like this has to do screening mammogram because of the high risk. His doctor suggests, because he has the disease, that he do a mammogram, and a mass was found on the mammogram. This is the ultrasound, and this is the mass. Okay. This is a mammogram showing a regular 2D in the side view. This is the pectoral muscle extending to the armpit, this dense area. We can see some masses here, but it's not well defined. So this is the 2D, and this is a 3D with the sectioning. It outlines the masses. An ultrasound is done. So this is the surface, and these are the masses. So those are cysts, like I mentioned, anything that's dark, it's liquid. So those are what we call classic cysts. We do not follow them. We don't do anything. After menopause, they should disappear or become smaller. Lipoma are benign tumors. These are fatty cells that's found again all over the body and in the breast as well. Most of the time you can feel them. This is a mammogram, and this is a 3D actually. But because lipoma is fatty, it's hard to indicate or depict on the mammogram because it's the same texture as the fat or the fibroglandular breast tissue. But because it's palpable, the patient can feel it, we know where it's located. And this is the ultrasound showing the surface and this kind of oval mass, that's the lipoma. Anything that's fat, it's like bright gray. And it's palpable, meaning he feels it because you can see it's right under the skin of the breast skin. Now, phylloid tumors. Phylloid tumors can be both benign or malignant or cancerous, meaning 5%. And these type of masses or tumors, they have to be taken out, whether they're benign, non-cancerous, or whether they're cancerous because they grow quickly. And it's common in women of childbearing age. And it's similar features as a fibroadenoma. So again, this is a woman from our community. So like I mentioned to you before, I see more women of that's in the non-Black community are coming in for screening, whether it's a clinical or pain, and it's always false positive, meaning something is clinically indicated. They come to do the exam and there's no finding. And again, women in our community, Black community, are coming in when we have acute symptoms of the breast. So this is a phylloid tumor, sorry. And I had shown you the implant. So it could look like there's an implant here, but actually this is a tumor. And this patient, when I saw this, I was like, why did you not come in? I wasn't sure. I was taking care of my mother. This is the 2D and this is the 3D, and it outlines the mass. This is the ultrasound, and you see that it's percolating to the surface of the skin because there's not much room left in the breast. So that's the ultrasound of the mass. This is a CT chest, and you see it covers the whole of the breast. So this is the right breast, this is the left breast. Just be aware if you don't like to look at anything surgical. She had the surgery, they had to take out the whole of that area because they didn't have much breast tissue. They take breast tissue along the abdominal wall to complete that area. Now, here is another phylloid tumor. This phylloid tumor, like I mentioned, it's similar characteristics of a fibroadenoma, which is benign. It was characterized as a fibroadenoma. The patient had it removed. After pathology, it concluded that it was a phylloid tumor. So in that aspect, the patient had to come back to have another surgery to get more margin so that it does not come back. Okay, Paget disease. Paget disease is something that's really missed often and is underrated because it's usually itching around the nipple area. It's darkening. The nipple will become inverted, but before that, patient goes to the dermatologist, they're given a cream or so, and then only when they notice that the nipple is going in towards the breast, then they come for further consult. And it's usually common in women over 50, and usually they have another type of cancer with that. So here is a mammogram, the 2D, the flat view. So it shows that the nipple is going in towards the breast. Here is the mammogram, the 3D, and this is the side view. So if you look at this thick line here, the nipple is thickening, or around the nipple area, it thickens. And you can hardly see the nipple, you just see the nipple marker. And that's the flat view. It shows the nipple is in. Here's the ultrasound. So this area is around the nipple, and it shows the thickness of the nipple around. So that indicates that it's a Paget disease, which is a cancer, and the patient has to have surgery. Okay, now we're going to move on to routine screening. What routine mammogram screening? It's for patient with no family history. Patient with previous breast cancer after 5 years, they can go back to routine. And routine screening is every 2 years. That's our protocol here. Patient with atypical cells of the breast every 2 years. Patient with all the benign findings I mentioned before, routine screening mammogram, fibroadenomas, papillomas, phylloide tumors, and patient who had clinical assessment or some diagnostic assessment by the doctor or incidental finding on CT and MRI every 2 years. Now, people who should be doing diagnostic screening mammogram. So all the people who has any kind of mutation that can increase the risk of breast cancer. So like I mentioned, the male before, the Codin syndrome, the BRCA genes, and which is very common in the Black women, by the way. So the BRCA1 is higher percentage on the BRCA2. And patient who had the non-Hodgkin disease at an early age in their early 20s, and they had chest radiation, because the radiation was high, there's a higher increase of breast cancer, so they need to do screening. Like I mentioned before, mammogram, the dose is very low because we use 28 kVp. Chest, they use 120 to 140, and then in those days they were using higher doses just to treat that disease. And any patient with prior cancer, it's a routine screening, a depistage, sorry, not screening mammogram, sorry. Patient with atypical breast cells also. And all women over 40, I know in Ontario, they passed a lot, women on over 40. Quebec, they sent out the letter at 50. But my advice to our Black community, at least try and do your screening ultrasound at the age of 25 to 35. And now, if you ask your doctor to do a mammogram at 35, they are doing that now, as well as you could start, if you haven't had any mammogram and no family history, start at 50.
Just wanted to add to that, Lisa, is that in Nova Scotia, the age is 40.
Yeah.
But we're going to talk a little bit more about that in a second as well.
Okay.
We've got Nova Scotia and Quebecers here, so.
Yeah. So who should be having yearly mammograms and MRI? So anyone with the BRCA genes or any gene mutation should be having yearly mammograms and MRI. And yearly mammograms and ultrasound for the patient with the non-Hodgkin disease. And every 6 months or yearly screening mammogram, depends on what the doctor wants, some rather the 6 months or the yearly, for a patient with prior breast cancer and atypical cells. And every 6 months, mammogram and ultrasound for patients who are diagnosed with breast cancer or on hormonal treatment, which they're trying to monitor how the effect of the treatment on the mass. Okay, what is it stable? Is it decreasing or so? Now we go on to metastatic breast cancer. So 90% of breast cancer patients survive, but there's a 10% chance that the cancer can spread, metastasize, and it's spread usually in the lymphatic system or the vascular system. Some of the main organs that are affected by metastatic breast cancer are bones, lungs, liver, and the brain. And the curve, there is a 5-year curve for survival for patients with metastatic cancer. Now, prevention, or we call it prophylactic mastectomy. So who are the people that are going for that option? So some patients with high family history or high risk or a typical cell, they choose to have both breasts taken out. People with strong family history, the BRCA carriers, BRCA1 and BRCA2, or any other mutation, the ones that had the chest radiation, the non-Hodgkin disease, or patients that are diagnosed with breast cancer, some opt for a total mastectomy instead of partial, instead of being followed up. I mean, even though you have a complete total mastectomy, it's still advised to have ultrasound and even CT or MRI. When they do other images, you can help to identify if there's anything. But mind you, some people do have total mastectomy. They take out the breast, and sometimes they do have reoccurrence coming back in the scar, the bedding of the scar, because we have 3 layers of tissues in the breast, and they still leave 1 layer left, and then you can have infiltration of reoccurrence on that 1 layer that's left if all of the margin wasn't taken out. So here are some genes mutation. There's the BRCA1 and 2 for sure. There are these different types. I am not very familiar with them. I just know I see it on the patient history when they come to do their screening. So I would advise you, you speak with your doctor, you communicate with your family to find out if anyone has any of these mutations. And you can always ask your doctor, can I get a gene test, and how can I go about doing that? Okay, so now I'm going to do some case study. This is a 70-year-old patient. This is her mammogram. She had a mammogram in 2015. This is the side view, the pectoral muscle. This is the fibroglandular breast tissue. So this type of breast tissue is the second type of breast tissue, which is between 25 to 50% fibroglandular breast tissue. So that's 2015. She missed a year, 2017. That maybe there's a development here. Then she missed 3 years, 2020. And here you see it has developed into more glandular and lumpy. We did an ultrasound. So this is the ultrasound in 2015, and this is the ultrasound in 2020. So for sure, it shows a mass, and was ductal carcinoma. So very important to be consistent with your screening mammogram, okay? Now, this is showing lymph node. So again, this is a member from our community that came in with acute symptom. The lymph node was enlarged and she can feel it. And this is what a normal lymph node looks like. So lymph nodes it fights the immune system. So if there's an infection, the lymph node closest to that area that's infected will get enlarged. And some people with underlying disease has enlarged lymph node anyway. So people with lupus, leukemia, lymphedema, patient with breast implant, because it's a foreign body, enlarged lymph node, mothers that are breastfeeding, bacteria, enlarged lymph node. So this is a regular lymph node, normal lymph node. So this bright gray area is the hilum. This dark area is the cortex. So if the margin is more than 3 millimeter, that's the margin at the hilum, and this is the border of the cortex. If it's more than 3 millimeters, we're concerned about it. And lymph node cancer can spread in the lymph node. So this patient came in from our community, Black community, enlarged lymph nodes. This is what it looks like for sure. It's worrisome. She started treatment, and before the treatment, like I mentioned, whenever we do a biopsy, we put a marker clip made of titanium. So this is post-chemo treatment, and it shows that the lymph node has reacted well with the treatment because it has shrunk, but it still needs to have surgery. And this is the ultrasound, the skin, and you can see the mass is percolating towards the skin. So there was deformity of the breast. This is an MRI. MRI is just wave frequency that we use with a dye to help us see imaging. So this is the deformity of the breast, and this is the normal breast. MRI are done with some patient, depends on the type of cancer, to see the extent of the mass because it's very sensitive because we use the contrast dye, which is injected intravenously. And they usually do extra subtract like color images, again, indicating the extent of the disease before surgery. Okay, and now we come to self-examination. So I would advise us that at least we try to do our exam monthly, and usually they say it's usually 2 to 3 days after your menstrual cycle. So you can look at yourself in the mirror, look at the shape of the breast, look to see if there's inversion of the nipple is going in, look to see if there's dimpling, look for dark spots on the breast, nipple discharge. So know your risk, meaning know your both sides, communicate with your family if anyone has breast cancer or any mutation. Speak to your doctor to get screening. So again, so many non-Black or non-Black people community are coming in from the early age between 20 to 35 with no family history because of pain, because of a lump, and it's false positive, nothing is found. And when we in our Black community come in, we have too many symptoms, and it's sad, and I just feel we should be doing more, we should be communicating more, and this is a reason why I feel we should form more groups like that to educate each other. So know your risk, get screened, and know what is normal in your breast, and try to eat healthy. I mean, that is kind of underrated for me because there are people who have very strong regime of being healthy and they have breast cancer. So I will go through very quickly how we should do our self-examination.
Okay,
So
Lisa, can you just make that picture a little bit bigger for us? Some people
okay,
are saying it's
here,
pretty small. And
let's see.
while you're doing that, so Lisa's gonna show us how to kind of go through the
That
motions
okay?
of doing, yeah, oh, much better. Lisa's gonna show us how to go through the motions of the self-breast examination. What I suggest for you, for all of you participants, is you can take your camera off. We can't see you anyway, but take your camera off. And as she goes through it, check yourself at the same time. Okay. So that you come away at least having a little bit more knowledge because if not, maybe you do check and that's great. And if, for those who don't, this would be a great time to learn. So Lisa, go ahead.
Okay, so you can always do it in your shower with the shower gel or so, or do it in the morning when you're creaming yourself. So it's always good to put your arm up. Some people advise to do it lying down, but then again, it depends on your breast with the Cooper's ligament, etc. So to me, personally, I think it's better you do it standing. So you put the arm up. And like I had mentioned to you, the parameters before, so we want it under the clavicle, at least 1 inch under the clavicle, and the padding of your hand. So you go straight down towards the nipple, up and down. You can do it very hard and you can do it very light. You do it hard just because sometimes masses are very deep. And don't be worried if you think you find so many lumps. That's okay. It's better to have false positive than not finding anything or coming in to be checked. So you go to the motion, the up, down, you check the lymph node as well too, because I mean, it can spread in the lymph node. So inferior to the clavicle, going down to the contours of the breast, okay? And you kind of curve your arm like that. Now you can do the wedge. So again, from the clavicle towards the nipple. Towards the nipple, you let it overlap, okay? This is how I do it. Everybody has different technique, but this is how I do it. And I find it's effective for me. And I think the more you do it, you will find that it helps. And now what's the other one? We go circular, circular, and always towards the nipple, towards the nipple. And the thing about it, nipple, we miss so many lesions in the nipple. So it's always good to press on the nipple as well, around the nipple. Do not hold the breast like this to feel a nodule because it's glandular. You're definitely going to feel nodular breast tissue, but it's more the padding of your fingers. So that's it. And then you just look at the physical changes in your breast.
If you could
Okay.
actually, yeah, if you could just do the other side as well, just to get so that we go
Oh,
through
yeah.
motions of
Okay.
doing both
Yes.
sides. We got two breasts. So let's
So,
go. Let's not
yeah.
leave
So
one. Okay.
motion, and do it 2 or 3 days after your menstrual cycle because remember your breast is sensitive. I know some people's before or after. Going up to the nipple, up, you do the wedge, nipple, and then you do the circle. Again, clavicle, and then you end at the nipple and make sure you really press inward to the nipple. Okay, and that's it. Yeah, everyone's okay.
Yeah, sounds great so far. Thanks, Lisa, for doing that. By the way, Lisa's volunteered her time to be here, and we are really appreciative. I'm just looking through the chat now. If anybody else has questions, please feel free to post it in the chat. I'm just going to go through a couple of them that came in right away. So the first couple is from S. Johnson. So she's saying, my daughter has a family history of breast cancer on both sides of her family. And her breast tissue is dense, but she never had an ultrasound. So we were talking about this before, Lisa, when
Yeah,
when you first presented it, because I also found out I did a mammogram way later than I should have. I know
yeah,
that, but I did it eventually. And in the report, I also found out that I have dense breasts, which I hear is pretty common in Black women. I'm not sure, but I can tell
I
you that
think it
on
is. Yeah.
mine as well. When I got the results, everything was clear, but they told me I got dense, but they never mentioned that I needed an ultrasound. So this is very interesting because I know that in dense breasts, breast cancer is hard to find. So,
Yeah.
so so this is very common, and this is why we do think this presentation is because we want particularly Black women, Black people that have breast tissue to be able to advocate for themselves. So if you're not getting the ultrasound that you should be getting, you should be asking for it. So do you have any comments about that, Lisa?
Yeah, actually, I have a story. My niece is 35 and she lives in New York and she just went in to ask for a breast ultrasound and they said, do you have any family history? And she said, no. And they said, well, you have no indication to do a breast ultrasound. You're too young. And she said, no, for myself, I would like to know. I really, and she persisted. And they did do an ultrasound for her. They found like maybe benign finding fibroadenoma, so they will follow up. So what I have to say, like I said, us Black women, I'm seeing non-Black community coming in early 20s up to 40. So I think we need to be proactive
Mhm.
and as early as 20, indicate to your doctor or communicate to your doctor you would like to have a requisition to do a breast exam,
Yeah.
ultrasound. And
And this,
at least at the age of 35, do
mhm.
your mammo because the risk is so high among Black
Yeah,
women
exactly.
that I think they are taking requisition for at the age of 35 now. And before we used to do like just the two views, like the side views.
Yeah.
Now we're doing the complete full views for the mammogram at 35.
Yeah, I think you bring up a good point, and that's especially for Black people, we have higher disparities at everything under the sun. Every single disease, we die faster, we die sooner, and we're dying younger from preventable diseases, right? And so when they have these protocols of, it should be 40 years old, we should get your mammogram, or 50, we should be advocating for ourselves and pushing back and saying, no, I know that, and I did that just the other day with my daughter. She went to see her the OBGYN for her first, appointment. And I said, she was saying, oh, pap smear is supposed to be done at 25. I go, no, you know what? We're Black and we have higher incidences of all of these diseases. I want her to be screened sooner. And the doctor said, okay, no problem.
Yeah,
So, had I not fought for it, then it wouldn't have happened, right? And this
yeah.
ties in nicely with something that Dawn F mentioned. She says that in Quebec, they don't do mammogram under 50. If there's no family history, you have to pay if you want it one earlier. So, any thoughts about that?
Well, no, I mean, where I work, if you do it in a screening center, they will accept you. Where I
Hmm.
work, we have, like I said, so many non-Black community
Yeah,
patients coming in. Well, we only start at 35 doing
yeah,
mammo.
yeah,
Anything under, they give them an ultrasound. So I think be persistent. You have to be persistent. If that doctor says no, go to another doctor.
yeah.
Or most people are they're coming in for pain. They're coming in because they feel a lump, because lumpy breast. Uh, you have to really, because it's sad. It's very sad that we are only coming in when we have symptoms.
Exactly. And then, yeah, and it just complicates things. It's really good if you can detect it earlier.
Yeah.
So you're in Châteauguay. So Don F, maybe if you wanted to go talk to Lisa in Châteauguay
Yeah.
and get it done earlier. I'm just going to the questions. S. Johnson also mentioned, when is it indicated for a 2D versus 3D mammo?
Well, with the government hasn't accepted the screening program hasn't
Mhm.
accepted 3D mammogram because in the States they do it, but I guess the Quebec government is a little bit peculiar.
Yes.
So they don't do screening, three mammogram with 3D, but if it's diagnostic, meaning the patient feels something or the doctor feels something, you will do the 3D. So anything that's clinical, they will diagnostic, they will do the 3D.
And is the
If
2D
you have
versus,
the government letter,
okay,
we refuse, the radiologists refuse because of restriction to do the 3D. They can start off with the 2D, but if the radiologist thinks that there is something to go under the radar, they could say, okay, patient breast is dense, we think we see something, then you overrule the DP stage and you
yeah.
do the 3D. And
So,
if it's a doctor,
yeah.
not a Quebec letter, the patient comes in on her paper formula, she has symptoms, we will switch it to a 3D. So anything diagnostic, 3D, but under the government screening, 2D.
2D. So usually the typical one we get anyway right now in the machine is a 2D, right? Is that correct?
Yes.
Okay, so with the 3D mammo, is it a different machine? Is
It's
there
the
different
same, it's the same machine, same
okay.
imaging, it's just an application that's applied.
Ah, okay.
So it's like post enhancement or whatever, and
Okay.
gives you it just goes at an angle, so maybe it will go 2 seconds more than the 2D.
Okay. Well, that's not asking for very much when you think about it at the end of the day. So it
Yeah.
doesn't hurt to ask for a 3D right away. Um, so you kind of went over signs and symptoms. We just want to review and make sure that we got this clear. When do you suggest we come in? What signs and symptoms should we be looking for? It's another question that came in.
Yeah. So if you have nipple discharge,
Okay.
and mainly bloody nipple discharge, that could indicate that there is a blocked duct or a papilloma. Any yellowish pussy discharge, If you have the nipple that's perking in, going
Hmm.
in, if you think you feel something when you do a clinical assessment,
Right.
uh, those are reasons to come in. I'm telling you, I see people come in all the time for pain, and we usually say we don't do screening, ultrasound or mammogram for pain, but it's done. So it could be done if you say you have pain.
Yeah, it's always best to err on the side of caution, especially with Black
Yeah,
people. Like, I'd rather over test myself than than just because I want to be on the safe side, right? And it's not
yeah,
because I'm being a hypochondriac or anything. It's that
yeah,
the statistics working against me, right? That and the reason why is because the intergenerational trauma or post-traumatic slave syndrome, that trauma that we live with, that's been passed on for generations. That racism is a trauma, um, so, and if you had childhood trauma, that's added trauma, right? So that trauma increases those cortisol levels in the body, and it really doesn't give our bodies a chance to repair itself, right? And so it really makes our bodies weaker. And this is why we're so susceptible to all these different diseases at early ages. So it's really important that we are aware that this trauma exists in our community, but we can do something about it, right? And just be proactive.
yeah.
Um, Sharfia, I hope I pronounced your name properly. She was very got personal here, and I thank you for opening and being vulnerable here because everybody can learn from this. She says that I had two precancerous lumps in my left breast. I had surgery and radiation. I am not taking the 5-year pill. Do I need a mammogram every year?
Yes, you do. And that's the issue. Again, I'm seeing a lot of Black people in our community. They had breast cancer 2 years ago. And why is it recurring again 2 years after?
Yeah.
So definitely you have to continue your screening every year. And if you have dense breasts, you have to know that you need to alternate with ultrasound or even MRI. And then I'm sure you're taking the tamoxifen for the 5-year period. So definitely. And this is what I find us, Black community, we're not followed up thoroughly after we're diagnosed.
Yeah, exactly.
So we need to be proactive.
Nora has a comment. She says, thank you, Lisa. If your doctor ever denies an exam or treatment, ask that they write in your file that they are denying your request and their reason for doing so. So paper trail, really important. I love
Yes.
that. Love that comment,
Yeah.
Nora.
Yeah.
Uh, Vanessa has a question. So, how would you further advise Black women with dense breasts who doesn't have accurate knowledge of family history? For instance, many of us would not really know if one of their older or past relatives had breast cancer because accurate knowledge of some illness was not shared in the islands, for example.
Yeah. So
So how
when
would
you
you
do
advise some
your,
people, yeah, women with dense breasts?
yeah. So when you do your mammogram, they give you the report. So they're gonna write dense breast. They're gonna say A or B. So A is like dense breast on your report. B is the second type, fibroglandular, and C is the fatty. So when you get your report, please try to understand it. Ask, communicate with your doctor. What type is it? Or you can get your report for yourself. So now
Mhm.
you know what type of breast you have. So if you have dense breast, speak to your doctor. Can I have an ultrasound? But most of the time, the radiologist, if in a diagnostic center, they will say mammogram, ultrasound, alternate the mammogram 2 years.
Yeah, perfect. Um, we also before, we were talking about the BRCA gene. I was thought this very interesting because I know that, like you mentioned earlier, Black women have a higher incidence, a prevalence of the BRCA gene. Um, so genetic testing is what I understand is what we would need to do to be able to find that out.
Yes.
Is it just a matter of asking our doctor to say that I want some genetic testing done, and how is that done?
I think usually it's like that, but if you have no imaging or you're just doing your screening or routine mammogram and you want to find it, you need to speak to your doctor or the hospital where you're doing your screening, we do have some pamphlets that we give out, and we said, call this number. I don't know much about it,
Okay.
but you can always communicate with the clinic or hospital where you're doing your screening.
Hmm.
But once you're diagnosed with breast cancer, they
Yeah.
do offer you the gene test.
Okay. Okay. Thank you. So I don't see any other questions or comments. Oh, oh, Vanessa had just popped one in there. Oh, and Sharifa mentioned, thank you, Lisa. We are not followed properly. And Vanessa is saying, is there time for a second question? Oh, do you have one? If so, can you share a situation where a Black woman, I think she's finishing off her thought here. I was going to give her a second. In the meantime, while you get that question going, I'm just going to share my screen. Tell me if people can see that. Um, And basically, I just want to tell you a little bit about the Health Association of African Canadians again. So we've been around for 25 years. You can find out we have our website at haac.ca. And we're actually revamping our website, so we're going to be launching a new one. But if you take a look at that and just peruse that, you'll see a lot of information. You can become a member. In Quebec, you can become a member just for free, just to kind of keep up to date with what's going on. But there is an affiliation that's starting in Quebec, and we officially launched it today. So if you're interested in being part of an affiliate version of Hawk in Quebec, please email us at BLLW, Black Lives Living Well, BLLW at hawk.ca, and we'll make sure that you get connected with that. Um, um, I will also be sending, there's this Black Lives Living Well booklet that was created and there's a video that goes with it. But basically the Black Lives Living Well booklet is a booklet that's offered, and the goal is to give it to every single Black person in Canada. So we're trying to print 1.5 million of them.
Wow.
So far we've got started. And basically this is a booklet that was done in partnership with the hospital here in Nova Scotia, and the Health Association of African Canadians, and the Black Lives Living Well. And basically the goal is to just talk about what's going on in the Black community and how we are dying from preventable diseases, and systemic anti-Black racism takes a place in that, and all the traumas I mentioned earlier. So this is a booklet that's really going to help to give you basic information on how to take care of yourself, some wellness tips to set goals for yourselves, details to share with your health provider, your doctor, your nurse practitioner. There's a doctor to doctor section. And just information on where to report in, if you in Nova Scotia, if there is a line that we can go to if we experience health discrimination within the healthcare system. I'm not sure if there's similar ones in Quebec, but that's something that Hawk, the affiliation, would be looking into for sure. And then there's a section to track down your numbers. So they list the ABCs, how we need to know our A1C number, our trauma number, anxiety, depression. There's some checklists there. Blood pressure and cholesterol. There's chronic screening. So for different diseases, it gives you an idea, a guideline as to when you should get these screenings. So today, Lisa talked about breast cancer screening and when to do that. But like we said before, for Black people, you need to ask for it sooner. Just to be on the safe side, ask for it sooner and be very proactive in that way. Like I mentioned, there's some screening tools in the booklet, just to kind of check in, and just some tips on healthy living. My favorite part is the doctor to doctor section, because we got a group of Black doctors that came together, and I asked them, what do you as Black doctors want white doctors or non-Black doctors to know about Black health? And so did you know that for blood pressure, there's certain medications that work better on Black people? So these are the kinds of things that we need your
Good.
doctor, your nurse practitioner to know about so that they give us the right medications that work better for our bodies. So this is a section you actually show the doctor, your nurse practitioner, say, I need you to read these few pages so so that we can make a plan in terms of what I need to do for my health. And then different resources. And then this is a section at the end of the booklet to write whenever you go to the doctor or your nurse practitioner, care provider, you can record your A1C level right away, your blood pressure, your cholesterol, and keep track of it and be proactive again. So there's also a video that we also did. I'm not going to show it now, but I will send the link so that you can take a look at it. It kind of goes with the booklet. Um, and um, and that can give you some more information. And we ask you to share it widely with your friends and family until we actually get the hard copy book. Okay.
Okay.
Um, coming soon, if you haven't signed up already or don't know about it, June 3rd, 2025 at 7 p.m. Eastern, 8 p.m. Atlantic. We're going to be having our Dr. Yinka. She is a family physician and she is passionate about skincare. And you're going to love her. This is an encore presentation that we're offering to both Nova Scotia and Quebec. And it's called Melanin Myths, Black Skin Misconceptions. And you'll see that there's 2 QR codes. Now, we did separate it for Nova Scotia and Quebec, only because we want to kind of keep the email separate for the Eventbrite, so that when we send out information, we can send it out only for Montreal, Quebec, whatever information, whatever's happening in Quebec, you'll know that. And then we do the same for Nova Scotia. So it's not the end of the world if you do one or the other, but we're just trying to keep it a little bit neat. So if you could just comply with that, that'd be helpful. And again, tell your family and friends. And if you have other suggestions on things you want to learn about or concerning Black health, please send an email to bllw@hawk.ca with those suggestions, and we'd be happy to find a way to incorporate it and bring more teachings like this to online. So I'm gonna see if okay, so I'm gonna ask you the last question there. So if so, can you share a situation where a Black woman with breast got the additional screening and ultrasound recommended, and early breast cancer was caught? Do you have any examples of that?
Yeah, we do well, Black women, like I said, um, I don't recall. Listen, I don't. That's the sad part. We don't have many Black women that the cancer is caught early.
Yeah,
That's my issue.
yeah, I hear you. I hear you.
And for example, like case scenario I can give. Some patient, there's a patient. She did her first mammogram at 50 because she got the letter from the government in Quebec. First mammogram, and there is a cancer, a mass.
Wow.
So there, you do it early because
Yeah,
she waited.
yeah,
This is the time that the DP stage starts. First mammogram, a cancer, and it's very emotional and shocking for people.
it
You
is.
think
It is.
I'm happy I'm getting my first mammogram, and to be told it's a cancer.
Yeah, yeah, that breaks my heart. Yeah, we just need to. We really, really need to be proactive. This is our lives we're talking about here. And so other comments coming in. Thank you, Lisa. You stressed a lot of good tips on prevention and self-advocacy. I'm looking forward to the new booklet. Okay, so I'll send the booklet out by email to you all. Another comment. Thank you so much for that booklet and video. Will we receive a copy of the webinar to our email? So this webinar is being recorded. We're not so much sending copies, but we will be posting it on our website. And we do have a YouTube page. So we will be posting it there. So keep an eye out for that. If you go to hawk.ca, especially when it launches, it'll eventually pop up there. But yeah, there's a lot of information here today, so I'm glad it was recorded so you can look at it at your own time and you can share it with your family and friends, right? And then it's a booklet downloaded. Yeah, so I will it's going to be on the Hawk website as well and on the new version when it comes out. But I will, since I have everybody's email for those who came, I will send you a copy of the booklet. Now there's two versions. One's like the national version versus the Nova Scotia version. So the Nova Scotia version has a little bit more resources for in Nova Scotia. The national one is just more national resources. But it's always being revamped, so that at some point in time we can, each iteration, comes out. Um, but apart from that, we got some thank yous. And so I hope you really enjoyed this evening. We want to end on time because we value your time. Um, but thank you again, Lisa, for sharing your knowledge and your passion about this. This is so well needed. We really just need to advocate for ourselves because other people are not going to do that for us. And so the more information we have, the more empowered we can be to do that, And I thank everybody here for being here and taking time for you. We're going to try to do these kinds of webinars fairly regularly, different topics, but remember that this is about your health and we want to help you along your journey in terms of making sure that you have the tools you need, the skills you need to be able to do so. We don't want this to be our webinars to be too academic. I'm very solution focused. I have a background in rehabilitation, and so I'm very focused on solutions. So again, if you have any topics that you're interested in learning more about and wanting to know how to manage it, please let us know at bllw@hawk.ca. Oh, this is great.
Okay, good. Thank you, everyone,
So
for
much. Thank you, everybody, for coming.
coming in. Thank you, Dr. Lisa. And
Yes.
okay, bye.
Bye.